a 28-year-old female presents with a 3-week history of high fever, night sweats, weight loss, and progressive shortness of breath. I am showing you a posteroanterior chest radiograph and an axial high-resolution chest computed tomography scan. Describe the findings.
The chest radiograph demonstrates diffuse, symmetric, fine nodular opacities measuring approximately 1 to 2 millimeters in diameter throughout both lungs. Individual nodules are tiny but visible due to summation. The high-resolution computed tomography scan reveals numerous small, discrete, 2-millimeter pulmonary nodules with a random distribution, involving the subpleural surfaces, interlobular septa, and bronchovascular bundles. There is no significant pleural effusion or consolidation. These findings are highly characteristic of a miliary pattern, with miliary tuberculosis being the primary diagnosis.
How is this infection disseminated to the lungs? How long does it take for these nodules to become radiographically visible? And what is the characteristic computed tomography distribution of miliary nodules?
Miliary tuberculosis is disseminated to the lungs hematogenously, resulting from uncontrolled hematogenous spread of Mycobacterium tuberculosis. Because of their tiny size, miliary nodules are difficult to see early on and may take up to 6 weeks to become apparent on a chest radiograph. On high-resolution computed tomography, they show a random distribution, which means they are scattered uniformly throughout the secondary pulmonary lobules, including the subpleural surfaces, distinguishing them from centrilobular or paralymphatic patterns.
What other infectious and non-infectious conditions can present with a miliary pattern? And what is the immediate clinical management?
Other infectious causes include disseminated fungal infections like histoplasmosis or coccidioidomycosis. Non-infectious differentials include miliary metastases from papillary thyroid carcinoma or melanoma, sarcoidosis, and pneumoconiosis like silicosis. The patient requires immediate hospital admission and strict airborne isolation in a negative pressure room to prevent transmission. Sputum samples must be sent for acid-fast bacilli smear and culture, and quadruple anti-tuberculosis therapy with rifampicin, isoniazid, pyrazinamide, and ethambutol must be initiated. In addition, an HIV screening should be performed, and we must assess for extrapulmonary disease, including choroidal tubercles on fundoscopy and tuberculous meningitis via lumbar puncture. I would contact the infectious diseases team immediately.